Okay, let's get rolling. We have one case to discuss, but the facility that submitted it is not on. So we will hold that case to the back end, and I'm going to turn us over to Veronica. This is the last of our 4 sessions on continuous glucose monitoring, and I think the most important, because this is how we stay in business, by providing high quality services to patients and figuring out ways to actually get reimbursed for our expertise and commitment. So it's all you.
All right, thank you very much. So last but not least, got that big old disclaimer. That's for me. Last but not least, we're going to do part 4, and we're going to talk about how to make money, which is important to all of us. So for course 4, we're going to talk about billing and coding, the cost of professional device, return on investment, and then billing codes. So for those of you who have not been doing this, we're going to get some beginning knowledge of billing for this CGM insertion as well as interpretation. So just by way of a brief review, when we look at CGM, we want to look at getting some benefit for our buck. And what we're looking at is, why should we use CGM? And one of the benefits of CGM is that it certainly is a cost-saving mechanism. An article done by Foos in 2015 looked at the cost of treating hypoglycemia. And when they looked at direct care costs for people with type 1 and type 2 diabetes, and they looked at folks who required assistance from a healthcare practitioner, the cost was almost $1,200, compared to when those events were treated by a non-medical third-party personnel, such as a spouse or someone else, it was $66. And if they took care of themselves, it was $11. So you can see there's a significant increase in cost when the hypoglycemic event requires a medical personnel to assist. The indirect costs were not as significant, but still, if you had a person who required non-medical assistance, it was $242. If it was severe, requiring some medical assistance, indirect cost was $161. And for self, again, $11. And that was for folks with type 1 diabetes. For people with type 2 diabetes, the non-medical care cost, $579. And severe with some medical care, $176. And then again, patients taking care of that hypoglycemic event themselves, $11. So the graph that you see there is of a study that was done on 120 patients with type 1 diabetes who were aged 10 to 65. And what they were looking to see is how CGM could prevent hypoglycemic events. And the top with the triangles are folks, that's not what I want to do, pardon me. The top of the triangle are folks who were on the standard care, and then at the bottom of the circles are folks who are on continuous glucose monitoring. And what you can see is they looked at folks over 6 months, and the people who were on continuous glucose monitoring spent less time being hypoglycemic. They also had lower A1Cs. They spent more time in range than those folks who were doing standard of care. And the standard of care folks did get intermittent CGM, but it was not as powerful as the people who were on continuous glucose monitoring throughout that 6-month study. So there is a benefit to using CGM. So we did talk about who should be on CGM. And certainly folks with type 1 diabetes with history of severe hypoglycemia, hypoglycemia unawareness, or frequent hypoglycemia. And it is also found to be beneficial when you're trying to lower A1Cs in patients with type 1 diabetes over the age of 25, has not been as beneficial in the younger population. The folks that I did not put here who are also benefiting from CGM are those folks with type 2 diabetes who are on sulfonylureas, secretagogues, insulin, anything that could potentially cause them to have a hypoglycemic event. So those are the people that you're going to be looking for in your practice for putting on CGM, as well as those folks who are not at goal and you can't quite figure out what is going on.
So this is a typo, right? The last line on the right column is frequent hypoglycemia.
CGM, maybe just where am I? Here? Yes, no, it's not, that's not typo.
Okay.
So you can use, excuse me, because what you want to do when you're using CGM, you have to put the right ICD-10 codes in. And so the code that you need are those folks with type 1 or type 2 having hyperglycemia or hypoglycemia.
Okay. Good.
So you do want that hyperglycemic in there.
Okay.
So that is the folks that it is indeed approved for. So yes, it is hyperglycemic. So when you look at jumping into purchasing the CGM, you got to count up the cost. And the cost, depending on which provider you want to use, can vary significantly. So we'll start with the real-time, which is the Dexcom device. And with the Dexcom device, there is a considerable cost. The receiver at $349, the transmitter at $399, sensors you get 4 in a pack at $249. So that's about $1,000 investment just jumping in. The nice thing about a lot of these programs is they will offer you a package deal depending on how much you want to do. When I did mine initially, I did a package deal for a year. And so the package deal comes to about $2,000. Because what they do for you for your package deal is every month they'll send you 4 sensors so that you don't have them sitting on your shelf, because they do have a shelf life. And that's one of the things to think about when you're thinking about doing a sensing program. There is a shelf life to all of these products. So although your receiver is good, my receiver I've had for 2 years, your transmitters for the Dexcom expire in 6 months. I must tell you, I managed to get a year out of my first one. But that's not usual. They're expiring in 6 months. And then the sensors, when they send them to you in the package, they have a shelf life of about 3 to 6 months. So you have to think about, do I have enough patients to warrant this cost? When you look at the blinded or the retrospective packages, Freestyle Libre is cheap. So their reader is $65. They send you about 10 batteries for it. And then their sensors are $60 per sensor. They also do the package deal where they send you all the cables and all that stuff that you need, and it's about $500 for the reader, the cables, and you get 4 sensors. So that your starter package is about $500. Again, the sensors for them expire in about 3 months. The Medtronic, I have to tell you, is not a package that I purchased myself. So from their most recent costing, if you do the iPro 2, if you do not do a package deal, just the iPro device is going to cost you about $1,400. And then the soft sensors run $175, $176 for a pack of 4. So the cost, depending on which product you choose, can be considerable. But you do have to think about also cost of your staff time. So time for insertion, instruction of the patient on use of the device, removal and downloading of the device, cleaning of the device, getting your prior authorizations, as well as for cleaning supplies and battery and all of those things. So there is a cost associated with it. The Dexcom, for what I have found real time, it's certainly, you can make your money back at it, and I'll show you that down the road. But when you're thinking about the device, certainly think about shelf life. Am I going to have the patient population to use the device in, and is this going to be a reasonable investment? So the part we all want to talk about, billing. I hate billing personally, but I'd rather just do my work and somebody else worry about the bills, but it doesn't work that way. So when we think about billing for CGM. There's some important steps to take, and I will tell you, any one of the devices that you choose, when the rep or whomever you meet with or look at online, they have wonderful structured packages that walk you through every step of this process, very similar to what I'm going to do for you. But there is some pre-work that needs to be done, and when you think about getting reimbursed from insurance, you have to think about your patient selection. You need to verify their insurance benefits. It is a covered benefit for Medicare. Medicaid follows Medicare fairly closely. And then the commercial insurances, you will need to get a prior authorization. So you have to submit for prior authorization, knowing that, and I tell my patients, it will take up to a week sometimes to get a prior authorization. A lot of times you'll call and they'll say, no prior authorization needed, you can just go forward. But if there is one needed, you need to be sure that you have documentation of that prior authorization number that you received. Because when it comes time to fighting denials, you will need that information. So that should be documented someplace in your patient's chart. If it is a self-pay patient, they will need to pay for both of the CPT codes, the 250 and the 251, and that needs to be clarified with them up front. But once you have completed your pre-work, then you're ready to schedule your patient visit. But there should not be a visit scheduled until you've done all of that pre-work. I got these flipping in. So after you've done your pre-work, then the steps that you follow in order to be sure that you've got all of the components included for your 250 billing. So inserting the sensor and educating the patient. And I tell you these steps this way because this is information that needs to be documented in your clinic note. So you have to say that patient came in, inserted the sensor, the place that you inserted it, the patient was educated on use and care of the device, and when you ask for them to return. You have to have at least 72 hours of data or you cannot bill. And then the patient comes back in, you remove the sensor, download, and generate your reports. All of this is going to go in your 250 code. So when you look at your 250 code, and this is what it's going to say on every piece of information that you ever get, it's an ambulatory glucose monitoring of interstitial tissue fluid via subcutaneous sensor for a minimum of 72 hours. And I cannot stress that 72 hours enough, because if you get a denial, you have to have a printout of that download in order to submit. So you have to have at least 72 hours of data on that download when you go to fight the insurance company. In there, as I said, your note's going to talk about sensor placement, hookup, calibration or monitoring, and you can do that calibration. There's a sheet for most of those that come, and it says that your high level is set at this, your low level is set at this, and I want you to test this many times. I scan that information into the patient's chart so they can see that we've talked about that. And that's included in your patient training piece. The removal of the sensor and then print out recording. And of note, you'll hear this more than once, you cannot repeat this more than once a month. But up to once a month, so if you decided, okay, my patient's on a goal and it's been 3 months and I want to do it again, you can certainly do it again and bill the same way. But you can't do it more often than once a month. If you have that patient who is coming into clinic because they've got, I don't know, cold, flu, whatever the case may be, and you've got a significant visit aside from placement of CGM, you can bill your EM codes with a modifier, a -25 modifier. And in that way, you get the 99213 as well as the 250 code that you can bill at the same visit. For me, since my primary practice is diabetes, I don't do any modifier codes. But you can do modifier codes if there's something that is significant. It can't be, patient asked me about whatever, and there's no significant work attached to it. There has to be significant work attached to it. You can use the -25 modifier and get paid for the CGM, either the placement or the interpretation, as well as your clinic visit. Questions about that?
So if a patient came in for their kind of 3-month or 4-month diabetes follow-up visit. And we're reviewing all of their meds, we're doing a foot exam, sort of a conventional office follow-up visit. And could we use the modifier
You
for
can use
that?
the modifier then.
Okay, so you could do this at the time of a routine visit
Correct.
and add it, okay.
The reason I don't do it at the time of routine visit is I don't
Takes
have
too
a
long.
prior authorization.
Right, there you go. Okay.
So, but if you get a prior authorization, you know your patient's coming in and they've been, as my patients will do me, they've been emailing you, telling you their blood sugars are out of control, then I can get a prior authorization prior to their routine visit, do everything I would do at their normal 3-month, 4-month visit, and place a sensor as long as I've got that prior authorization. And I can bill for my 99214 as well as the sensor placement.
Jan, did you have a question?
Yes, thank you, Victoria. I'm Veronica. Sorry. Does the modifier go on the 95250 then?
It can go on either one.
Okay.
So it depends on if you've got a significant thing at the visit where it's placed or where it's downloaded and interpreted. So it can go with either visit.
So it could, but it doesn't go on the 99213. Okay. All right.
So the 99213 is probably not going to be a significant enough visit to attach to it, but you get to determine that. They don't tell you that you can't use it with 13, but it needs to be a significant visit.
Right. Okay. Thank you.
Okay. All right. So then you've done your pre-work, you place the sensor, and now comes your step 3, which is for me the most fun. So it's interpreting the report. This can be done with or without the patient in the office. And for me, that's the beauty of it. So what I have my patients do, they get placed on the medical assistant schedule for the most part. They come in, the medical assistant takes the sensor off, downloads the data, and scans it to me. Then at my leisure, I will call the patients and talk about what was found on the sensing report, and I bill at that time. You can do it either way with them sitting in front of you, or you can do it as a phone visit. You can't send them a letter in the mail because that doesn't count, but by phone or in person is perfectly fine. So when you think about your 95251, again, it's an ambulatory continuous glucose monitoring of interstitial fluid via subcutaneous sensor for a minimum of 72 hours. It should be a separate visit, has to be a separate visit from the 250. Should be separate and billed separately. The interpretation is by MD, PA, NP only for the review and the interpretation. If you have patients, and I put this in as a caveat, because if you have patients with a personal CGM, which a number of my patients have a personal CGM, you can bill them for a 251 at each visit. So if you've got, but no more than once monthly. So if you've got a patient who has to come in to see you for, I can't even think of routine things, hypertension. So you manage their hypertension. So they come in, they get the blood pressure checked, and you're changing their blood pressure medications, and they just happen to have on a CGM. You download that and review it, you can bill for that. So so you can, and that's only on their personal devices, that's not on your device. So on their personal devices, you can bill for that at each 3-month visit if they've got a CGM that you are interpreting the data for them at those visits. Again, as I said, interpretation does not need to be face-to-face. And because people get tangled up in the weeds on their office visits, if you're doing an office visit different from looking at their data, again, you can use the 25 modifier with the 251 code as well. So reimbursement, money back. So when you think about the cost put into it, Medicare for your placement will pay you $159.69, and for the interpretation, $44. Commercial insurance, as you can see, is significantly more. I personally have not seen the $303 because I don't have a lot of commercial insurance. And then for the interpretation, they'll pay $87. What I have seen is with Medicare, I usually get between $160 to $117 for placement. So they pay pretty well for that. For the interpretation, I get anywhere from $79. That's on a commercial. But for Medicare, I will get anywhere from the 44 and down to about 32, but usually not less than 32. Some of the commercial insurances, I've only got like $25 back for an interpretation. But because I do primarily Medicare and Medicaid, Medicaid pays almost as well as Medicare, which has been significant for me. So the money that you make back on it, because we did a 6-month audit of placements for me, and what I found is that I probably, for a 6-month period, I would clear about $5,000. But that's just based on the number of sensors that I put on. So the biggest thing about it is being sure that for every sensor that you place, that you have an interpretation report. Some of my monies did not add up because the interpretation report, my billers did not know where to look for those interpretations. So if you do interpretations by phone, if you don't do your own billing, then you need to be sure that your billers know where to look. All of my placements are done in the office, so they know where to look for the office ones, but the phone interpretations, they need to be instructed as to where to find those so that they can bill for those appropriately.
So maybe you're gonna, is the cost of the supplies built into these fees?
As far as
The sensor?
built in, as far as the Medicare
Yeah,
payment back?
yeah. So is there a separate charge for the sensor, or is this just the charge for the insertion and prep, etc.? And is there a separate fee that's charged to Medicare to buy the?
No.
So the cost of the materials
Everything
is
is
embedded
built in.
in it. Okay.
Everything is built in there. You don't get any.
There's no, right.
No separate monies.
Okay.
So the beauty of it for me was that my devices were purchased from a grant, but I made all my grant money back.
Okay.
So, but because you really do want to be sure that you're getting a good return on your investment. So, and that's why you want to think about which device you purchase. So those are the monies that you can get back. As I said, I don't have very much commercial insurance, so I have not seen the $303. And the commercial insurance that I have is if United Healthcare pays pretty well, and Blue Cross Blue Shield. Not Anthem Blue Cross Blue Shield, just a plain Blue Cross Blue Shield. Some of the other payers, I have not seen as much of a return on the investment.
When you said $5,000 in 6 months, I mean, how many were you basically?
So, and that was a slow 6-month period for me,
Yeah.
because after I used my initial funds, getting how do I say, getting a restock of my supplies was a little costly or painful. But anyway, so I only placed about 10. So, and then some of those they had to find the monies for my interpretation. Yeah, so I had a slow 6-month period. So once you have decided that you're going to purchase your device and you've done all your billing, there can be some increased clinic costs. So the increased clinic cost comes, one, when patients walk away with your devices. My patients sign an agreement. If you lose this, you don't bring it back to me, you will pay me $5,000. They sign it, I scan it to their chart. I only had one scare where I had a patient who walked away with my Dexcom device, ended up admitted to the hospital. And hospitals are very scary places because they lose things. So my heart was beating a little fast. It took her 10 days to bring it back to me, but she did bring it back and apologized profusely.
But that same box with the dentures.
Right, the dentures get thrown out always. But you will find if your patients have their personal device, that's the place they always lose them. If they ever they're in the hospital, it's going to be gone. So for this patient, she had not taken my device to the hospital with her. She kept the sensor on, but she had not taken the transmitter to the hospital with her, the receiver rather, to the hospital with her, which was a good thing. So she did bring it back, and it was at 10 days instead of the 7 days that are requested, but it did come back, thankfully. So You want to be sure that patients sign their agreement and bring your devices back to you. And the other thing is you have to set up a plan to identify the patients so that it is utilized as much as possible. What you don't want to have happen to you is for your sensors to sit on the shelf and expire, because that is a huge cost to you if you do not use them. So once you've identified your patient population, it needs to be enough patients, because most of the sensors come in a pack of 4. It needs to be that you've got 4 patients lined up when you make your first order. You also need to review your denials on a routine basis, because that's where money is lost, because the insurance companies will come back when you bill them and say that you never got a prior authorization. Once you send that prior authorization number back to them, usually there's no problems after that. And you always want to be sure that your 250 codes have a matching 251 code for each patient, because again, as I said, that's where your monies are lost. So when you get a denial, the reasons for the denials are kind of listed here. You have to remember that not all payers will cover. So what I say to my patients is this: I would like to place a sensor on you. If your insurance does not cover, so usually we get a prior authorization. Sometimes the person will tell you things like a prior authorization is not needed, but it could be their first day on the job. So they tell you prior authorization is not needed, then you don't get a prior authorization, you send out a bill, your bill is kicked back. So what I've learned to say to my patients is this: if your insurance does not cover, you need to be willing to pay X amount. And patients will sometimes glibly say, oh yeah, that's fine. I haven't had anybody refuse to pay, but it is something to think about depending on who your payer mix is. And other reason for denial, as I said, you didn't get a prior authorization. Prior authorization, prior authorization. I can't say it enough, because they will kick you back. Was it medically necessary? So when you think about it, it can't be just for the joy of placing a sensor, like I did on Carmela, that's for fun. But it has to be medically necessary in order to bill the insurance company. So you got to have that documentation. You know, I've seen this patient, their A1C is not at goal, they report feelings of hypoglycemia, but they don't have any documented on the 2 times a day that they test. So you have to have all of that documentation. And then when you submit your appeal, you need to have that CGM tracing. So that CGM tracing has to be at least 72 hours or they will deny you. So you have to have all your ducks in a row if you need to do an appeal. Did you use the proper ICD-10 codes? And that's where the hypo and the hyperglycemia comes into play. If you put in a simple code as 11.9, 10.9, you are not going to get paid. You have to have a modifier. So you've got to have the 1065, which is type 1 with hyperglycemia, 1165, type 2 with hyperglycemia, 10.641 or 649, because that's hypoglycemia with or without a coma. So those codes need to be there. Otherwise, it is deemed by the insurance company not to be a proper code, not to be medically necessary, because you have no documentation of hyper or hypoglycemia. And when I talk about hypoglycemia, also for patients, if I have patients who have reactive hypoglycemia or patients who just come in and tell you, oh my gosh, I've been having all these feelings of low blood sugar. If you put in a hypoglycemia code, that's with or without diabetes, just a plain hypoglycemia code, place a sensor, you can get reimbursed for that as well. And then did you bill correctly? The 250 and the 251, but on separate visits, never together, and then including a modifier if you need that. So take-home messages are these. You need to identify your patient population prior to purchasing. Like I said, you want to have at least a minimum of 4 patients lined up that you can use this on right out of the gate, so that you can make your money back before you make your next purchase, if that's the way you want to do it. But you do not want to have these things die on the shelf, because that's money wasted. You got to determine the right system for your office. So if you think that you're going to be doing a lot of these, but you have patient population that you want them to be able to see that their blood sugars are high or low, then you certainly need to have a real-time device. If you're just doing it for your information, you don't want your patients to be heavily invested in having anything to do, you want 14 days worth of data, then you want to go with a retrospective Libre device, which, as I said, is also cheaper. So you just need to determine what's the best system for your office. Again, be sure to obtain those prior authorizations, and I think I've said it 5,000 times, but that is extremely important if you want to get your money back. And then ensuring that you have the proper ICD-10 codes, because if the codes do not reflect hypo or hyperglycemia, you will not get paid. So my contacts, which are in the PowerPoint, these are the folks for the Northern Nevada area who are responsible for the devices. They can get you the information you need, get you set up. They're the folks that will talk to you about package deals based on how much use you think you will have of the device and cost and all of that. They will also provide the trainings to you on how to use your device, how to set up your computers in order to download the devices. So they are great resources if and when you decide that you want to incorporate this into your practice. Questions?
So this is really something that can be done. This is low-hanging fruit, I think, and it adds so much value to management of patients. And you know, it's like everything else that we do in medicine. Till you actually do it yourself, you don't really have a great handle on what it's going to be like, or also how much you're going to learn by doing it. The issue, I guess, is how do we get our clinic managers to buy in? Because there's going to be an upfront cost. No matter how we do it, there's going to be a little bit of front loading for the purchase of some equipment, and we need to be able to, demonstrate to our bosses that this is going to work. And I think the point about lining up the patients in advance is the key. But I got to believe that in all of our practices, there are lots of patients for whom this is going to be beneficial. And as long as you've got someone who, if you have to do all of these steps yourself, you're going to resent it a little bit, I think. But if you have an assistant who can be trained, and it's easy to learn to do this, who can upload the data to the computer, print it out for you, you can select in all of these the reports that you think are most valuable. It's not rocket science, and we would be thrilled to back you up on this. So if you monitored a patient and had a download and you wanted some help, we'd be happy to go over it, and walk you through it. Yes.
Can you hear me?
Yeah.
Okay. I just wonder, for rural, we're in a rural clinic here in Yerington, and so the billing is all different than normal. That's what I'm told. Yeah. So do you happen to know, would the CPT, the billing just seems different with the rural facility. There are different rules. Do you happen to know how this, would apply to a rural facility, rural healthcare facility?
So when you say different, is it because you have a different payer mix? Because I really don't understand it, but I think there's like it's a set fee for Medicare and Medicaid, no matter what you do. So even though we still code our visits, it doesn't really matter because it's a set fee. And if it's private insurance, then it's different. Then I think it's normal billing, but it just seems like anything with billing, I don't know. But that's what my understanding of how our billing process works.
So I think that's a great question. So it sounds to me like you bill just the same way that federally qualified health centers do. So, which is basically patient walks in the door, ka-ching, there's a set predetermined fee for that. And I think that's true. And I think that that would work for the patient coming in and having the sensor inserted. That would count as a visit, which I think would more than pay for itself. And for the follow-up, I think each one of those is a ka-ching on your cash register. The issue is purchase of the equipment and purchase of the sensors. I believe that this still makes financial sense, and we could walk your billing people through this.
Because when you talk about set fees, Medicare has a set fee for placement and interpretation. So if they put that code in, that code goes to Medicare and they have a set fee. You don't have to calculate how much you need to bill for that. So just like them walking in the door, there's a set fee attached to that. It's the same thing for placement and interpretation. There's a set fee attached to it. There doesn't have to be a lot of extra thought behind it for the billers if the code is there. They submit that code.
So the startup cost is this 4 sensors, basically, or the 4 pack?
Yep.
Okay.
So it depends on which set you want. So when you think about startup costs, as I said, depending on what information you want, Libre is always going to be the cheapest startup cost. It's about $500 for going forward. So that's your batteries, your charger, your reader, and 4 sensors. So the other systems are more expensive startup. So you're looking at $1,000 to start up with a Dexcom for real time. And you're looking at considerably more than that for the Medtronic startup. I think it's like $1,600 or something like that for them.
But the Libre is not real time.
The Libre is not real time, it is retrospective.
Right.
Yeah.
But it works really well.
It works fantastically.
So like how, do you happen to know like what number of patients does it take to not lose money? Just the 4. Basically, if you treat 4 people with it, is that?
If you do the Libre and you put it on 4 patients, you've already made your money back.
Yeah. Okay.
And then the next 4 is pure gravy.
That's right. The next 4 is money in the bank.
Right.
But you have to have be sure you got your codes and your prior authorizations.
Yeah.
Your codes and your prior authorizations, and then you get your money back.
Okay.
But the Dexcom could take 5 or 6, so it would be purchasing a second 4-pack.
Correct.
Probably.
So, and the Dexcom I use primarily because I have so many type 1 patients, and so if you've got for me, if I've got a patient with type 1 diabetes who comes in, has got an A1C of 6.5, and their glucose log looks more like an A1C of 10, that's where I'm using it. So I use my Dexcom more on my type 1 patients. On my patients with type 2 diabetes that I've got some concerns about, 14 days worth of data is fantastic. I use my Libre.
Yeah.
So I really am very kind of judicious on who I'm using which device on. But for my Dexcom, I want to be sure, because I usually order 8 at a time, that within 2 months, I need to put 8 of those on.
Okay.
So you want to maybe create a log, you want to sort of, Smith, that's a patient, and just start to create a little database for yourself of patients for whom you think this is appropriate when you hit that magic number, 40 plus.
And when you order, the turnaround time is pretty quick. I mean, most of them will get things to you. Libre gets things to you in about 2 days. Dexcom takes a little bit longer.
Can't order on Amazon, right?
Please don't.
But the reps are fabulous. They're all really nice and helpful. And remember, their goal is to make this easy for you to do it. They will do that.
Jan, did you have another question?
Yeah, we were just one comment and one question. We're having difficulty getting the sensors at the Southern Bands Indian Health Services because we go through a Merck and they're not at the Salt Lake City distribution center, and so just that's I'm sure that'll be resolved eventually. But there is a delay getting them from the manufacturer to the distribution center that we use.
Yeah.
Which one are you using? Which device?
It's the Freestyle Libre, and we're just going to be training on it on Tuesday. So we've got the reader. It only cost us $65, and we didn't have to pay for any cables and things, but I haven't opened the box to see what I'm missing. So
You should have at least one cable and 10 batteries in that box.
okay, well, I don't think I have that. But then my question, Veronica, was how do people respond when you say, I'd like to, type 2, for example, how do they respond and how open are they to this?
So I usually set them up pretty good. So I don't like to see any patient without a glucose log. You either bring me a glucose log or a meter, or I tell you this is a social visit. So when they bring in that glucose log or that meter, and most of them are testing, maybe 4 times a day, but as a rule, for people with type 2 diabetes, if you get 2 readings, you're doing really, really good. So they will come in, and that morning reading is beautiful. That evening reading is sporadic and usually a little bit high. That A1C doesn't match anything that you see, so the conversation I have with them is this. I see your blood sugars are beautiful in the morning. I have no idea what you're doing the rest of the day. Your A1C is out of control. In order for me to have more information and you not have to test yourself 6 times a day, I would like for you to wear a sensor. Usually you get, okay, because that's less work for them to do. I said, in 2 weeks, I can get the information I need in order to help you improve your blood sugars.
All right, that sounds like motivation. Yeah.
And I think that you want them to know that they're taking a bunch of meds oftentimes, and you want to optimize that. You're trying to make the medications they're taking work as well as they could possibly work. Sometimes what you can tell them is they're going to need less medicine, so there are real payoffs for the patient. Cool. Right. Any other questions? All right, so I think our one case is our presenter is not with us, so I think we will hold off on that. It's not a diabetes case, and maybe we retire a bit early today. Great, so we will see you in 2 weeks.
Thank you.
Okay, bye.